Hello and welcome back, everyone. Today we are going to speak about headache and migraine. We are going to cover the pathophysiology and clinical pharmacology, drug therapy, how to approach patients suffer from migraine, what type of algorithm or guidelines we have it for the migraine. Speaking about migraine, migraine is known as a common recurrent primary headache of moderate to severe intensity. Migraine may interfere with normal functioning and associated with the gastrointestinal symptoms or like neurological symptom or autonomic nervous system symptoms. What we are going to focus here in our session, we are going to focus on the pathophysiology and then what is the best approach for the patients suffer from migraine. As you can see here, the main component responsible for the migraine is like a cranial nerve. This cranial nerve called trigeminal sensory nerves. And this trigeminal nerve, when this nerve activated, this nerve will release vasoactive peptide. This vasoactive peptide causes several consequences. But what type of peptide will be produced from the trigeminal nerve? As you can see here, we have calcitonin gene-related peptides, CGRP. So from now and so on, we're going to say CGRP, calcitonin gene-related peptide. Then we have neurokinin A. Then we have substance P. So we have several factors responsible for the like mediators or like neuropeptide released from the trigeminal nerves. When this peptide released from the trigeminal nerves, this peptides or neuropeptide cause vasodilation in the brain blood vessels, cause extravasation of the plasma and leading to the inflammation. So number one, vasodilation of brain blood vessels. Number two, we have extravasation and inflammation. Number three, we have mast cells. The mast cells will be maybe affected by degranulation. The mast cells will release their contents to the circulation, to the brain. And at the end, we have activation of nociceptors. The nociceptors, this is a receptor for the considered like pain receptor. So as you can see here, we have several components: vasodilation, extravasation, inflammation, mast cell degranulation, and activation of nociceptor. We have some genetic factors may play a role in the migraine and response to the various triggers. We have some people maybe produce sensitivity to some of these triggers, other people to different triggers. We're going to speak about the triggers of migraines. Then we have the specific type of receptor responsible for migraine. This receptor called serotonin 5-HT receptors. So we are going to discuss that in details in the next coming slide. Okay, so as you can see here from the diagram, what we have here, we have activation of trigeminal nerve, the cranial nerve 5, activation of this nerve by the trigger, or the activation will trigger the release of vasoactive peptide. We have three main peptide there: calcitonin, CGRP. We have neurokinin A. Then we have substance P. This will lead to the vasodilation, extravasation, inflammation, and degranulation of mast cells. And this the end result that concluded by activation of nociceptors or like pain receptor. Okay, this is the neuron trigeminal nerves here. As you can see here, trigeminal nerves. This trigeminal nerve, when is activated, this will activate CGRP, substance P, and neurokinin, and cause pathophysiological changes in the brain: vasodilation, inflammation, muscle degranulation, and activation of nociceptor. Okay. Again, we need to look on the slide here. In the preganglionic, we have two main type of receptor belong to the serotonin receptor here. You can see it on the graph. We have the serotonin receptor 1B, 5-HT1B. HT stand for 5-hydroxytryptamine, HT receptor. Then we have 5-HT1D receptor. So we have two main receptor on the trigeminal nerves. Okay, so even we still have the same pathophysiological approach here, because we know now the what type of receptor do you have in the trigeminal nerves. We have some medication bind to this receptor, activate this receptor, and lead to the therapeutic benefit. So two main group of medication will affect this receptor, and this medication considered like agonist. When we say agonist, mean that these medication activate the receptor. Please remember that agonist, any agent or medication activate the receptor. So moving to the next, you can see here we prescribe triptan or ergotamine to the patient. Triptan and ergotamine bind to the 1B receptor here, bind to the 1B receptor as you can see it, and this will lead the 1B receptor, and at the same time triptan ergot bind to the 1D serotonin receptor. The result of this binding between triptan and the receptor 1B and 1D, the result will be blocking the release of granules from the neurokinin, substance B, and CGRB. And the consequences or the result, the benefit result will be, instead of vasodilation, we are going to have vasoconstriction. Instead of extravasation, we are going to have less extravasation and decrease inflammation. We are going to have less activation to the nociceptor and the relief of acute pain. So we can ask question here, which of these medication considered like agonist for the serotonin receptor 1D, 1B, and used for acute pain, acute migraine treatment. So we can speak about triptan and ergot. Triptan and ergot, two medication used for the migraine, for acute migraine attack. So triptan and ergot, how this medication work? By stimulate serotonin receptor 1D and serotonin receptor 1B. Okay, the clinical presentation here, the patient may come to the clinic suffer from headache that characterized by recurring episodes like throbbing pain, a frequent unilateral pain, could be half of the head. We have some neurological symptoms such as phonophobia, photophobia, hypersomnia, and difficult concentration. We have other maybe symptoms could be associated with that, such as anxiety, depression, euphoria, irritability, drowsiness, hyperactivity. Could be stiff neck, yawning, thirst, food craving, and anorexia. Some patients may suffer from numbness in the arms or face, dysphagia, or weaknesses. Okay, so we have the patient now suffer from migraine. How to approach the patient here? This is important maybe steps for us. As you can see here, number one, we have two type of approach. Number one, we need to prevent the headache. So we have a migraine prevention. So we can go the migraine prevention, or we can go the acute treatment. So we have two main approach. Number one, the patient suffer from acute attack of migraine. We need to relieve the pain in this patient. So we have some medication belong to the acute treatment. And the patient come to the clinic and he or she does not willing to suffer from migraine. We can prescribe some medication to prevent from migraine attack or prevent recurring migraine. Minimize disability and emotional stress, enable the person to resume normal activity, and decrease visit to the hospital or to the clinic. So all these considered like goal of therapy. The goal of therapy, number one, to prevent the attack, to treat the acute attack, minimize the disability, and allow the person to practice normal activity, and at the end decrease the visit of the person to the emergency room and to the clinic. Okay, how we can manage the situation, how we can approach the patient? We have two main section. The first one, non-pharmacological approach and pharmacological approach. Non-pharmacological approach, this one should be started first. Try to identify the triggers of migraine attacks. Do you have any triggers? For example, coffee, smoking, chocolate, some maybe noisy, anxiety. Try to avoid these triggers. Second, we have behavioral intervention, could be like cognitive therapy or any other maybe relaxing therapy, biofeedback therapy. Some people may maybe feel relaxing or relieve the pain with applying ice to the head, or take a period of rest or sleep, sitting on the dark room, and so on. So we have non-pharmacological approach to the we need to start with this step before we move to the pharmacological treatment for the patient. Okay, here in this slide, this session here, we can see trigger category, and we have triggers here. The patient may suffer from a trigger towards the food, or like environment, or like psychological factors. For example, here you can see the caffeine, for example, nitrate for some processing food, chocolates, some saccharin, for example, aspartame for the diet soda, diet food, tyramine, for example, light, attitude. We have tobacco, for example, fatigue, menstruation, sexual activity. All these make stress, for example. All these may trigger the migraine. So for this reason here, we have to take this in consideration and try to avoid these triggers. Okay, could be food, could be environmental, could be psychological triggers, as you can see here from the list. Okay, now we have the talk. Now we can speak pharmacology. I like the pharmacology. What happened there? Acute migraine therapy. So if the patient suffer from pain, and the patient come to the clinic, emergency, suffer from pain, this is a list. We can use it for patients suffer from acute pain. Okay, so we have patients suffer from acute pain. Which medication? All these lists could be prescribed to treat patients with acute pain. But we have guidelines. We need to follow these guidelines. Okay, for medication, analgesic, for example, we can go with the Tylenol, acetaminophen, or we can go with the Tylenol with aspirin, caffeine, Excedrin, for example, available like combination therapy, and OTC, no prescription needed. Okay, so number one, acetaminophen, or acetaminophen plus aspirin and caffeine, number one. Number two, this is number one. Okay, number two on the list here, non-steroidal anti-inflammatory drugs. Could be aspirin, ibuprofen, naproxen, diclofenac, ketorolac, and ketorolac nasal or IM injection. So we have list of NSAID could be used for acute migraine therapy. CGRP antagonists. We have Brogibant, Ubrelvy. We have Rimogibant, Neurotic, ODT. ODT stands for oral disintegrated tablet. The tablet can be put on the tongues and able to dissolve in the saliva. ODT, Rimogibant, Brogibant. This one belong to the CGRP antagonist. Then we move to the ergotamine tartrate. Ergotamine tartrate, we have it like coming like a tablet here, as you can see, coming as a tablet, oral tablet with caffeine, cover cut, and we have sublingual tablet, Ergomar. We have rectal suppository with caffeine, cover cut with the microcut, and we have dihydroergotamine available like injection, dihydroergotamine 45 injection, nasal spray, migrainal nasal spray dihydroergotamine. Okay, moving to the triptan here. Okay, moving to the triptan, as you can see here, speak about triptan, we have the prototype first medication in this list. We have somatriptan. Then we have zolmitriptan, naratriptan, rizatriptan, almotriptan, frovatriptan, ilitriptan. Okay, so for somatriptan is available in several pharmaceutical forms. You can see we have it like injection, we have it oral tablet, we have it nasal spray, we have it powder, nasal powder, transdermal patch, zolmitriptan, nasal spray, oral tablet, naratriptan, all these oral tablet. So we have all the somatriptan available in so many forms. The other available or restricted to the oral form. As you discussed that in the beginning, some patient may suffer during migraine, before or after or during migraine, may suffer from nausea and vomiting. For this reason here, we can prescribe some antiemetic medications such as metoclopramide and prochlorperazine or bromethazine like Phenergan, Regelan, and Combazine. So we have a list of medication could be used for acute migraine therapies. Start from Tylenol, moving to the NSAID. Then we have CGRP antagonist, ergotamine, dehydroergotamine, triptan, somatriptan, zolmitriptan, and almotriptan, rizatriptan. If the patient suffers from nausea and vomiting, we can go with the antiemetic medication. Okay, this slide here demonstrates the diagnosis and treatment of migraine as maybe simple guidelines to understand how to approach patients suffer from migraine. As you can see here, we start with the diagnosis. Okay, we start with the diagnosis. Then we have patient education. We discuss the general wellness and try to discuss avoidance of triggers factors such as food, environmental factor, or psychological factors. Then we start with assess the headache severity, the migraine severity. Do we have mild migraine or we have severe migraine? Does this migraine like moderate migraine, mild migraine, or severe migraine? If the migraine associated with the nausea and vomiting, we need to consider using like anti-emetic medication. This could be like suppository, could be injectable, or could be a intranasal formulation. So we have different approach for the patients suffer from nausea and vomiting. Number one, try to use the anti-emetic drugs if the patient suffer from nausea and vomiting. Try to explore another maybe medication for migraine, such as suppository, parenteral medication, or intranasal medication. Speaking about this is the acute, this is the treatment here. This represents the treatment of migraine. Then we have another one speaking about prophylactic treatment. So we have two approaches here, even for the treatment or for prophylactic. For the treatment, if the patients are from mild, moderate, start with acetaminophen, Tylenol, as you can see here. Or we can use NSAIDs such as aspirin, ibuprofen, and naproxen. If this medication enough, that's good. Persist with that. If this medication is inadequate, we move to the combination therapy: acetaminophen, aspirin, caffeine, and so on. If the patient suffer from severe symptoms, so migraine with the severe symptoms, start using the triptan and or dehydroergotamine. So triptan or dehydroergotamine will be the option for the severe acute migraine. If the patient if the patient come to the clinic and try to use some medication to prevent migraine, we are speaking about prophylactic treatment. Okay, regarding the patient suffer from nausea and vomiting, as you can see here in this slide, if the patient suffer from migraine with severe nausea and vomiting, we have maybe the different approach. We are going to use some medication to consider like anti-emetic medications. We have metoclopramide, as you can see, metoclopramide, Regelan. We have chlorpromazine, prochlorperazine. This one could be the pre-treatment with the anti-emetic drugs, because if the patient suffers from nausea and vomiting, we cannot prescribe the medication to the patient. We cannot prescribe any medication orally to the patient. Okay, we recommend to use it like 15 to 30 minutes before the oral or non-oral migraine therapy. If the patient suffers from nausea and vomiting, you use this medication to relieve nausea and vomiting, then we will prescribe the medication. What is the benefit of metoclopramide? That maybe someone may ask here. Is it only for nausea and vomiting? Is it only for nausea and vomiting? So if the patients are from migraine, it's not only for nausea and vomiting. As you can see here, the benefit. Number one, it provide anti-emetic effect, alleviate nausea and vomiting. Number two, reverse gastroparesis. Gastroparesis is kind of paralysis of the stomach. This will improve gastric empty. This number two. Number three, enhance absorption of medication, and this will enhance the absorption of oral medication. Here we are speaking about triptan or ergotamine. Okay, the first group of medication used for the migraine, we have ergotamine and dehydroergotamine. Ergotamine useful for moderate to severe migraine attack. Ergotamine considered like non-selective, Non-selective medication by stimulate serotonin receptor 1, could be stimulate 1B, 1D, and so on. And this will lead to the construction of blood vessels in the brain, intracranial blood vessels, decrease inflammation in the trigeminal system, trigeminal vascular system, and this will affect not only the nervous system but will affect the veins and the arteries that cause construction. Ergotamine available oral, as you can see it here, available oral, sublingual, and rectal. So ergotamine, we have it in several pharmaceutical form. Okay, another type of ergotamine. So ergotamine oral or rectal, and could be contained combined with caffeine. We have another form of ergotamine called dihydroergotamine. Dihydroergotamine available for intramuscular, sublingual, IV could be prescribed, but this one should be in the hospital. So we have it IMSC. Okay, that's good. Nasal for outpatient. So dihydroergotamine, intramuscular, subcutaneous spray, outpatient. But if you talk about IV, this one should be for the patient in the hospital only. Any side effect? Yes, ergotamine associated with nausea and vomiting, and with ergotamine derivative. Ergotamine may cause severe peripheral ischemia. This reminds us with the Raynaud phenomenons, and this is called ergotism. And the patient may suffer from diminished peripheral pulse and claudication, continuous paresthesia. Patient may be predisposed to the gangrene, extremity gangrene, myocardial infarction. Here, someone may say, we are speaking about peripheral vascular and myocardial infarction. Here we are talking about not the cardiac muscle. We are speaking about coronary artery. And this medication causes spasm of the coronary artery, and for this reason, this medication may cause myocardial infarction. This medication may cause hepatic necrosis and brain ischemia, and with some rare cases here. It's not like popular in the clinical practice, but we need to remember that this medication causes peripheral ischemia, severe peripheral ischemia, and could maybe lead to the gangrene. Okay, so now what is the policy? How we can use this medication? If you use ergotamine, we don't recommend it to use it with the triptan. So if you decide to add triptan, okay, we need to stop the ergotamine 24 hours, then start with the triptan. So don't use ergotamine derivative and triptan within 24 hours of each other. So we need, if you decide to switch the patient to the triptan, you need to stop the ergotamine at least for 24 hours, then you start with the triptans. If the patient suffers from renal failure, hepatic failure, coronary disease, or cerebral disease, peripheral vascular disease, not allowed to use ergotamine. And the pregnant woman and nursing woman during nursing or lactation is not allowed to use this medication, ergotamine. Ergotamine available, as you can see here, oral tablet with a caffeine, because caffeine enhance absorption. Oral tablet, Covergot, the name Covergot, and we have sublingual tablet, Ergomar. We have suppository. We have dihydroergotamine. With the dihydroergotamine, we have it injection, DHE 45. For the nasal spray, we have Trudesa, and we have Magrenal as a nasal spray, dihydroergotamine, or dihydroergotamine injection, DHE 45. We need ourselves to be familiar with the generic name and brand name for each medication. Ergotamine tartrate as administered sublingual, ergotamine tartrate available injection, dihydroergotamine available like nasal spray. You can see, if you go back to the slide, you can figure out which one will be maybe the appropriate answer for each case 1, 2, 3 from the Ergomar, Covercourt, and so on. Okay, moving to the next section or next topic that cover migraine, we have serotonin receptor serotonin receptor agonists here. Okay, serotonin receptor agonist. That means this medication stimulate the receptor again. This medication stimulate the receptor and a group of medication called triptan. So I will repeat it: serotonin receptor agonist that able to bind and stimulate the receptor. And this medication bind to the serotonin receptor 1B and 1D and activate the receptor. So this medication activate the receptor, and this medication considered first-line therapy for patients with mild to severe migraine. Could be rescue therapy when we have non-specific medication are ineffective. For example, you prescribe acetaminophen. You prescribe acetaminophen, caffeine, and aspirin, and this medication is not are ineffective. Then we can switch to the triptan. We have the prototype. So the mechanism of action stimulate 1B and 1D serotonin receptor. The prototype medication, the first medication in this group, somatriptan, subcutaneous. This medication given subcutaneous injection, number one. This medication available intranasal, somatriptan. Then with this medication available oral. So if you're talking about subcutaneous, when you're talking about subcutaneous, this will provide rapid onset of action. If you prescribe it intranasal somatriptan, this will provide faster onset of action. So if you need like fast onset of action, go with a subcutaneous or intranasal formulation. If you use it on regular basis or for the treatment, we have oral tablets, and this will take roughly around, for example, 30 minutes to 45 minutes to see the action. Okay, so first generation somatriptan. The second generation, we have list for second generation. We have it in the next slide. What is the advantages? What is the characteristic of the second generation? Number one, second generation provide higher availability. Number one. Number two, longer half-life. So higher availability, longer half-life, slow onset of action, less headache recurrence. The issue here, if you prescribe, let me say you prescribe somatriptan to your patient. I will go there. You prescribe somatriptan to your patient. The patient, after, for example, 6 months of treatment, come back to the clinic and suffer from another attack of migraine, and you feel that somatriptan is not effective. We can switch the patient to another triptan. So if the patient does not respond to the one triptan, you can switch the patient to another triptan. So when the patient does not respond to the one, that does not mean the other medication will be ineffective. So switch the patient from one triptan to another until you are maybe achieve the effective treatment. Okay, some patients may suffer from flushing, warm sensation, and somnolence. Triptan contraindication, in general, this reminds us with the ergot. If the patient suffers from ischemic heart disease, the same with the ergot. We don't prefer to use it. Pregnancy, we don't prefer to use it. Hypertension, cerebrovascular disease, hemiplegic migraine or basilar migraine. So we have several contraindications. The most important one, ischemic heart disease, pregnancy, hypertension, because this medication causes vasoconstriction. Drug interaction, we don't recommend to use triptan and ergotamine with overlap for 24 hours. In other words, if you decide to switch the patient from ergotamine to the triptan, you need to give a period of 24-hour wash out in order to switch the patient. So the patient on ergotamine, stop ergotamine for 24 hours. After 24 hours from stopping ergotamine, you can start a triptan. This medication also is not allowed to use it within the 2 weeks of therapy of monoamino oxidase. If the patient on monoamino oxidase, we need to stop monoamino oxidase, wait for 2 weeks time, then start triptan. Triptan with the antidepressant. So triptan enhance serotonin receptor. Triptan stimulates serotonin receptor. And if you prescribe an antidepressant belong to the serotonin efficacy, this will lead to the case called serotonin syndrome. So because the situation, the serotonin will be increased in our body, and the patient may suffer from serotonin syndrome. Okay, here we have some symptoms of serotonin syndrome, like agitation, insomnia, confusion, dilated pupils, high blood pressure, muscle rigidity, loss of muscle coordination, twitching muscles. All these could belong to the serotonin syndrome. And this is related to the using of triptan plus antidepressant. For this reason, we don't recommend to use it together. Okay, moving to the list here to give you like a view or like quick review for the triptan. As you can see, we have somatriptan, we have zolmitriptan, naratriptan, rizatriptan, amlotriptan, vrovatriptan, ilitriptan. Somatriptan available injection, oral tablets, nasal spray, nasal powder, and transdermal. Zolmitriptan, oral tablets and nasal spray, and the rest of these medication, naratriptan, rizatriptan, almotriptan, frovatriptan, all these considered like oral. Okay. Okay, and the third medication. So we discussed the first medication was ergotamine, the second group of medication triptan, and the third one, this is number 3 here. We talk about number 3. Go back again. Okay, number 3 here. We have ditan, 5-hydroxytryptamine 1F. So here we are speaking about 1F serotonin receptor agonist. One medication, lasmiditan, Rayvoy, the Rayvoy, lasmiditan, indicated for acute treatment of migraine. So this one here, we need maybe to differentiate between acute treatment and prevention. So we have two cases here, acute treatment and prevention. Okay, so what we have here from the beginning until now, we have ergotamine, triptan, and lasmiditan. All these medication used for acute treatment. So as you can see here, lasmiditan tablets here used for acute treatment of migraine. This medication stimulates the serotonin receptor 1F. We can call this one like selective for 1F, able to abort the migraine attack by blocking neurogenic inflammation and and this will lead to decreased stimulation of trigeminal nucleus caudalis. Any side effect from this medication, because this medication provides specific effects, selective effect. They said this medication may cause drowsiness. This medication not recommended to use it in people who's driving motor vehicle or operating heavy machinery. So maybe the takeaway point for lasmiditan, this medication work on 1F receptor, agonist 1F receptor, number one. Number two, this medication used for acute treatment. This is number one, acute treatment. Number two, working on the serotonin receptor 1F as agonist. Number three, this medication may cause drowsiness, and it's not recommended to use it in people who are driving motor vehicle or like operating on the heavy machinery. Okay, lasmiditan. Okay, so we're done with the third group. So the group number 3. So number 1, we have ergotamine, number 1. Then we have triptan. Then we have lasmiditan. Number 3. Number 4, we have giptan. Okay, all these for acute, as you can see here. All these medication used for acute treatment. Ubrelvy and Neurotic, as you can see it here, the brand name Ubrelvy and Neurotic ODT, indicated for acute treatment of migraine. Giptan, we have brogiptan, rimagriptan, work by blocking the CGRB receptor. Block the CGRB receptor, and the result will be vasoconstriction and reduce inflammation, neurogenic inflammation. Okay, so better tolerated if you compare it with the triptan and lasmiditan. This medication better tolerated. This is good. Okay, the important issue here, if you remember, with the ergotamine and triptan, This medication not allowed to use in patients with a heart disease. Okay, ergotamine, triptan. But what they found here, giptan is we can use it here. We can use it in patients with the angina or heart disease, giptan. So we can use it safely in this patient. Rimagriptan demonstrate long half-life, 11 hour if you compare that with the Brogiptan like 5 to 7 hour. It's recommended if the patients are from renal or hepatic, severe renal or hepatic impairment to avoid using this medication. So again, as a summary for Giptan, two medication, Ubrelvy, Neurotic, stand for Brogiptan, Rimagriptan. This medication block the CGRP, decrease inflammation, induce vasoconstriction, better tolerated. We can use it safely in patients with a cardiovascular disease, but we need to avoid this medication in patients with the renal or hepatic impairment. Okay. Use of opioid in migraine treatment. We have a lot of opioid in the practice, but we don't recommend to use opioid due to the risk of tolerance and dependence or addiction. There is a risk of addiction, so we don't recommend to use it. And what we have in the practice, we have codeine, tramadol could be combined with acetaminophen as a maybe benefit treatment for the patient. Buterphanol, we have some studied established efficacy to use like nasal spray. So number one, we have codeine, tramadol, and acetaminophen as probably effective treatment. The buterphanol nasal spray established efficacy. They said they documented effective of this medication. We need to keep this medication as a rescue therapy. So what that mean here as a rescue therapy? Because there is a risk of abuse, there is a risk of addiction, there is a risk of dependence. We don't prefer to use this medication in the practice. We don't prefer it. So we need to go with, for example, triptan. We can try, for example, ergotamine. We can try lasmiditan. We can try the list of medications CGRP blocker or antagonist. Okay, so we have list of medications. If that's not maybe effective, we can think or we can start with using some opioids such as codeine, tramadol, and so on. It's not popular in clinical use for migraine. Okay. Almost done with the group of medication. I will go back again to remind you. Triptan, we discussed ergotamine, lasmiditan, CGRP blockers or calcitonin gene-related peptide, opioid if you add it to the list. Okay, then we have monoclonal antibodies. So for the monoclonal antibodies, we need to maybe differentiate it between, because we have CGRP receptor antagonist, then we have monoclonal antibody. Okay, for monoclonal antibody, as you can see here, we have erenumab, considered like CGRP receptor antagonist, and erenumab goes to the receptor, antagonize the receptor, erenumab, and used for prevention treatment to prevent migraine. Please remember, erenumab, number one, monoclonal antibody. Okay, goes to the CGRP receptor and block this receptor. So erenumab, erenumab, available like pre-filled syringes, block the CGRP receptor. So erenumab belong to the monoclonal antibodies, block the CGRP receptor. So erenumab. Okay, moving to the next medication here, we have UB or VIOB. Okay, so we have eptinezumab, CGRP antagonist indicated for prevention of migraine, prevention again for the migraine. We are going to discuss the difference between the group of CGRP, because we have three types of CGRP antagonist. Okay. Monoclonal antibody, again, we have two types. We have some medication directly block the CGRB, bind to the CGRB. So the CGRB here, uh, we have the CGRB like mediator, calcitonin gene related peptide. We have the peptide here, CGRB. This is the peptide. Okay, we have antibodies, and we know that the antibody become like, I will draw it another way. This is the antibody. Okay, this is a eptinozumab, for example, eptinozumab binding to the CGRP. So you can see here we have the eptinozumab block the CGRP. So bind and block the CGRP. Okay, what about the eronomab? Eronomab block the receptor. So eronomab monoclonal antibody block the CGRP receptor. Okay. Again, because we have this one before, and we need to remember this one, what happened and why we have it, and this is our target here, as you can see it, because it's already covered, calcitonin gene related peptide. Okay, it's already covered in the previous slide. Okay, this is what we have here. So this one here, this slide here demonstrates the activity of trigeminal nerves, sensory nerves. You can see here we have the neurons. The neurons contain vesicles. Inside these vesicles we have calcitonin gene-related peptide, and this vesicles release its content in the gap. Calcitonin gene-related peptide, you can see it here, and then this calcitonin gene-related peptide bind to the receptor. Calcitonin gene-related peptide bind to its receptor here, and will activate, cause vasodilation, extravasation, inflammation, degranulation, activation nociceptor, and cause migraine or pain attack. Okay, so we have it here only to like first image, and if you go to the second image, you can see the target for us. When you activate the trigeminal nerves, you can see it here, activate, release the content. Here we can prescribe CGRP receptor antagonist. This one block the receptor. CG receptor antagonist block the receptor. Okay, another group of medication, you can see it here, we have antibody. Antibody, we have two types of antibody. We have antibody for CGRP. You can see here the antibody bind to the CGRP mediator in the gap. Antibody bind to the CGRP mediator in the gap. Or we have antibody that bind to the CGRP receptor. So we have two types of antibody. Number one, antibody bind to the calcitonin gene-related peptide in the gap, to the peptide directly, or could be the antibodies bind to the receptor and inhibit the receptor. Okay. So you can see here the example for us. So CGRP receptor antagonist, we have rimageptan and brogeptan, Ubrelvy, and Neurotic. What about the monoclonal antibody that block the receptor? So monoclonal antibody block the receptor, we have eronomab. Eronomab, this monoclonal antibody MAB, stand for MAB. Monoclonal antibody bind to the receptor and block the receptor. Okay, moving to the monoclonal antibody that antagonize the peptide directly, we have eptinozumab. Eptinozumab, you can see the antibody here bind to the CGRP as molecules. Okay, I will repeat it again because it's a very important topic for us. When the trigeminal nerve activated, a trigeminal nerve will release the CGRP, which stands for calcitonin gene-related peptide, and CGRP will bind to the postsynaptic receptor, and could be in the blood vessels or on the brain or the other neurons, and cause vasodilation of the brain blood vessels, extravasation, inflammation, muscles, degranulation, and activation of the nociceptor, and cause pain. Okay, as you can see here, we have three types of medication affect the CGRP. We have the first group of medication, we have CGRP receptor antagonist. Then we have another group, like we have antibody. Antibody we have two type. Okay, so for the antibody we have two type. All these like considered like antibodies. Okay, antibody. This antibody could target the CGRP directly, could target the CGRP directly, or could target the receptor. Okay, example for this medication. Okay, as you can see here, we have three main groups that affect the CGRP. The first group we have it here. We have the CGRP receptor antagonist. CGRP receptor antagonist here. We have rimagibant, brogibant, Ubrelvy, and Neurotec. Then we have monoclonal antibody that block the receptor. We have Erenumab here. This antibody bind to the receptor and block the receptor. Then we have the monoclonal antibody that antagonize the peptide. You can see the antibody here bind to the peptide and the gap and block the peptide. You have, for example, eptinozumab. Okay, moving to the next maybe section or important section for us. So all these discuss the individual drugs, starting with the ergotamine, triptan, lasmiditan, with the rimagibtan and erenumab, and NSAID, aspirin. Okay, speaking about the prophylactic therapy of migraine, as you can see here, the purpose to reduce frequency and severity and the duration of attack, increase responsiveness to the acute therapy. We have approval from the FDA about using beta blocker, timolol, propranolol. We have approval for using topiramate, defaloprox, sodium. We have approval for using CGRP monoclonal antibody antagonists, as you can see it here, monoclonal antibody antagonists such as erenumab and fremonozumab, and another group of medication. And the purpose there, and it said the guidelines start with the low doses, increase those maybe slowly until you get the therapeutic effect with a lower risk of tolerance. We need to continue with the treatment for 6 to 12 months, and then we if you like to stop this medication, try to decrease this medication gradually. Okay, this slide is considered one of the most important slides for us because we always emphasize on something important. We are dealing with patient, not with the disease. We are dealing with patient, not with the medications. So what that means, if you have migraine, okay, you are not going to jump and use triptan. No, you are not going to jump and use, for example, ergotamine or lasmiditan or rimigibant, for example. We need to figure out, we need to look on the patient history, family history, drug history. We need to look on the clinical evaluation to the patient before we go to the next step. So for the migraine prophylactic treatment, pharmacology, we have different approach. We look on the patient. Does the patient have angina? Or is this patient, for example, does this patient suffer from depression? Does this patient suffer from epilepsy? Or this patient suffer from, for example, for the some type of triggers that induce migraine, such as menstrual migraine? When you have this classical migraine without any risk factors, we start with the NSAID or triptan. This is could be one option. Angina and migraine, we know that beta blocker could consider like one of the best medication for angina, and we know that propranolol used for prophylactic treatment for migraine. For this reason, the drug of choice for patients suffering from angina and migraine will be beta blocker. We will be propranolol. Moving to the patients suffering from depression, for example, if the patients suffer from depression and migraine, prophylactic treatment will be tricyclic antidepressant or venlafaxine. So we have maybe approach tricyclic antidepressant and venlafaxine. If the patient suffer from epilepsy, topiramate, drug of choice. Topiramate you consider like anti-epileptic medication to control epilepsy, and topiramate also used for prevention of migraine. Again, this slide here show maybe demonstrate or show us how to use medication to prevent migraine, but we need to look on the patient situation. Does the patient suffer from angina? Okay, does the patient suffer from depression? Does the patient suffer from epilepsy? Or like we have some predisposing factors such as menstrual migraine. If you talk about menstrual migraine or regular migraine, we start with the NSAID, Tylenol, acetaminophen, aspirin, ibuprofen. We can switch the patient or place the patient on Triptan. If the patient suffers from angina and migraine, prophylactic therapy, the ideal maybe choice will be beta blockers such as propranolol and timolol or other medication belong to the beta blocker, and we recommend something like lipophilic. If the patient suffers from depression, tricyclic antidepressant and venlafaxine. If the patient suffers from epilepsy, topiramate, one of the best medication, followed by valproic acid. Okay, if you maybe select one of these and the end result will be ineffective therapy, what we can do there, so we can move to the next step by prescribing CGRP antagonist. CGRP antagonist, you remember we have the medication there, and that medication work on the receptor or work on the mediators and on the mediators, or could be work on the use antibody. Okay, and the other option to use like combination therapy such as propranolol and tricyclic antidepressant, topiramate and NSAID. So we have option to use a combination therapy. Okay, at the end of this lecture, I would like to summarize the topic that covered in this lecture. We start with the migraine, and then we move to the pathophysiology of migraine and focusing on the three mediators, calcitonin, gene-related peptide, neurokinin, substance P, that cause vasodilation, inflammation, muscle degranulation, activation nociceptive. Then we move to the what is the main mediator responsible for this. The main mediator will be CGRP, substance P, and neurokinin B. And then we focus on the two type of receptor, 5-hydroxytryptamine 1D and 1B, and this receptor will be target for the triptan and ergotamine, and the triptan and ergotamine bind to this receptor 1B, 1D, and activate the receptor and cause vasoconstriction, decrease extravasation, decrease inflammation, and decrease pain perception. Moving to the, we discussed briefly the clinical symptoms and the goal of treatment, non-pharmacological approach. With the pharmacological approach, before we move the pharmacological approach, we have less of medication for acute treatment. So we need you to remember which medication for acute treatment and which medication for the prevention treatment. We discuss NSAID, acetaminophen, CGRP, ergotamine, dihydroergotamine, anti-emetic, nausea and vomiting medication. We cover all these, and patient education, avoidance trigger factor, for example. Also, we discuss the benefit of metoclopramide with you. Ergotamine, there is a risk of vasoconstriction and the risk of necrosis, the risk of gangrene with ergotamine. We don't recommend to use it on long-term treatment, for example. Then we move to the triptan, and we discuss that we have several types of triptan: first generation, second generation, and the triptan serotonin receptor and agonist work on 1B, 1D, considered drug first-line therapy for mild to severe, and considered like rescue therapy. Second generation, provide higher availability, provide longer half-life, provide slow onset of action, less recurrence of migraine. Then we move to another group of medication, lasmiditan. This medication work on 1F. Then we move to the geptan. We have rimegeptan, progeptan, and this medication could be used safely in patients with a heart disease. But one issue with the rimegeptan, progeptan, one issue here that this medication should be avoided in patients with the renal and hepatic impairment. Moving to the next CGRP monoclonal antibody, we differentiate between medication work on the receptor or medication work on the mediator. Prophylactic treatment, also we discussed several type of prophylactic treatment. At the end of this lecture, I would like to thank you for listening and watching these videos, and see you soon in next maybe lecture about another topic, and central nervous system pharmacology.